Good morning, Jaktan.
Yes.
Me, Professor Amal Kumar Choudhury. We work together few days in National Art Center. My respected chairperson, teachers, and special thanks to our scientific secretary, Dr. Professor Ajam, and dear learned audience. Very good morning. My presentation actually it's dedicated to my fellows. It is very basic, and to start the primary PCI, what complication you will face and how you will handle. So complication nowadays um very common in during primary PCI. So need to encounter how to encounter every complication we must know. Uh, Dr. Ajam gives me the topics, the handling complication of during primary PCI. We know STEMI is fire. Your house is on fire. The fire spread quickly. That means minute means muscle in STEMI. So need to extinguish the fire as soon as possible. My topics is different complication scenario and how to handle it. What does it mean, the complication during primary PCI? Means the complication to do PCI or angioplasty on contemplated culprit vessel or vascular excess. The most common complication of primary PCI is the acute vessel closure due to dissection, huge dissection, thrombus and spasm. Then no flow, no slow flow, and acute stent thrombosis is also very common complication than any other elective PCI, ventricular arrhythmia or any lethal arrhythmia and transient hypotension shock, bradyarrhythmia we can counter easily. So what are the challenge we face in Bangladesh? Chest pain, the traffic jam, the time is over, then encountered pocket money, then what the patient thinks, how it take decision. So most of the time cath lab is empty for primary PCI. All of you know the time frame, we does not discuss. But common complication of primary PCI and how to overcome, know the basic prevention, recognition and management. Prevention is better than cure, all of you know. My first case, 50 years known case of diabetes, cardiac arrest survival, anterior MI, infralateral. Plan for primary PCI. There is a moderate disease in the left system and total occlusion of mid RCA. Coronary artery dissection is happened, commonly encountered. During wiring, if not carefully wiring, during primary PCI, because the there is thrombus burden, hazy and soft plaque. So any subintimal dissection may happen. So what we will do? What is the clinical consequence of this? In fact, extension, reinfection, emergency CABG, even death may happen. The treatment is balloon and stent. How we encounter my case? We put a pedalate and we put a stent.
Listen. Good morning.
And the result is appreciable. My second case, 42 years, AMI STEMI anterior, planned for primary PCI. Repeated aspiration already said the previous speaker, but there is, I think, there is definite role to encounter the thrombus burden, slow flow, or no flow. And in primary PCI, it is about 12% and mortality is 8%. So what is the management? Forceful injection of blood, intracoronary, all the vasodilator, even then balloon sometime needed. So it's very clear. Even then slow flow, no flow is overcome by 2B, 3A receptor blocker and GTN and also deeper stenting. Third case, third complication. Anterior MI, anteroseptal MR, plan for primary PCI. Left system is almost, there is a severe left pen disease. Right side is almost normal, but patient undergoes the cardiac arrest, and at that time should keep panic, not be panic. And what could the region? BT, BF should be encountered very nicely. Asystole. Case scenario 4. ER embolism. Not only the culprit vessel, even then non-culprit vessel also sometimes the RCA is normal, but there is a ER embolism due to high adrenal surge and hurried. So keep in mind, ER embolism may sometimes produce the normal vessel, slow flow and no flow. How you will treat? And this is the ER embolism after primary PCI in the LAD. There is ER embolism. So how you treat? 100% oxygen, atropine, management of MI if it happened is massive ER embolism, thrombosuction, ER suction, and CPR may maintain it. RV perforation is not nowadays not common, but when we did initially the TPM, every patient of primary PCI at that time during TPM induced RV perforation was happened and is done managed conservatively. Stent thrombosis. How it managed? After 4 hours, this patient developed again ST elevation in the inferior surface. Sometimes we did not get the distal landing zone very clearly. So put a stent and some residual lesion may be omitted. At that case, it may happen. How deal? You thrombosuction and all the intercoronary dilator and then see there is a distal lesion and give another stent and the final result is appreciable. This is the culprit thrombus. Acute stent thrombus management, thrombosuction, you may use what is the region of this stent thrombosis. You can use imaging, be dilated again if there is underdilatation, confirm effective anticoagulant and optimize antiplatelet therapy, consider 2B3 receptor and strong antiplatelet therapy. 55 years, anterior MI, perforation, there is the nightmare during primary PCI, it is very, because the vessel is fragile, may happen anytime. Prolonged balloon inflation, not controlled, and cover stent also fail. Then patient sent to surgery and save the life. So management of coronary artery perforation, every fellow should know first hemodynamic support, volume replacement, ionotrope, pericardial synthesis, IABP. Seal the perforation by reverse the heparin, balloon occlusion, even sometimes given platelet embolization, if there is wire-induced distal perforation, coil, gel foam and thrombus, cover stent and lastly surgery. 50 years, STEMI inferior. I like to say there are two cases of thrombus burden. This is very good, just mild thrombus burden, aspiration and the good result. But another case, 50 years, STEMI inferior, there is a huge thrombus burden, repeated thrombosuction, but result is not good and defer stent because we did not find the landing zone of distal landing zone as well as proximal. So sent to the conservative treatment in CCU and there is all of you know that this is the class 3 recommendation sometimes. So conservative management by 2B3 receptor blocker or streptokinase is better. So there is some issue also and debate in STEMI, pasugrel and ticagrelor have replaced the clopidogrel in patient undergoing primary PCI. Newer antiplatelet agent must be used in primary PCI. And choice of stent, definitely drug-eluting stent is the choice of nowadays the primary PCI. And so STEMI with multifacial PCI debate is going on, but sometimes need to do, this is my last case, last complication. This is LAD also disease and RCA is inferior MI, STEMI inferior MI, 66 years. So I think in this type of cases, we can use the recommendation class 2B, both the vessel, we can do the PCI in the right side, P and post dilatation, and left side in the same setting, no problem, patient goes the third days go in. So my take home message, dear audience and respected chairperson, complication of primary PCI have decreased with routine use of improved technology and intracoronary stent. However, abrupt closure, perforation, atheroembolism, embolization and stent regret continue to challenge the interventionalist. Attention to prevention, recognition and treatment of this complication is essential and not so tough if experience and if head is clear and open. So knowledge of recognition and management of complications are vital for favorable outcome. I acknowledge my team and thank you to all for patience hearing.